Hello, everyone. This is Reed Johnson. I will be on vacation on the 13th, and so I unfortunately won't be able to be there in person. So I decided to take a video of me presenting my poster. And the poster I did is Take a Breath, Improving Fourth Year Medical Students' Confidence in Evaluating Hypoxia. And my mentor for this project was Dr. Soltis. And so the background of my project was that the transition to fourth year medical school to being an intern is accompanied by a significant increase in your expectations, performance, and responsibility in patient care. This is also the area of focus of a lot of medical education research right now. Dr. Soltis helped to create our transition to residency medical or course for medical students that was designed to be internal medicine specific and talking about the knowledge and skills needed to be intern. And I decided to focus on the hypoxic patient based on needs assessments that have been done by a couple other preceding residents like Dr. Heisel, Amanda Heisel, Dr. Sydney Bowmaster, and Dr. Taylor Cox. Um, the needs assessment data that I am using here is from Dr. Taylor Cox's survey, where on a 7-point Likert scale, he asks interns to rate their average comfortability in managing a couple of overnight concerns if they were to come up overnight. And the lowest was hypoxia. And so to address the perceived um, low comfortability that interns have in addressing hypoxia, I developed a 1-hour case-based interactive hypoxia workshop to be delivered to the fourth year medical students participating in the transition to residency course. And also of note, during the course, there was a 3-case rapid response simulation session designed by Taylor Cox, one of which of the cases dealt with a hypoxic patient, and they were hypoxic due to volume overload in the setting of heart failure. And there was also a lecture by Dr. Rappaport that addressed ventilator management, and then a lecture by a respiratory therapist addressing the different ways to deliver respiratory support, including oxygen support to patients. My overall objectives were to develop a framework for generating differential diagnosis for a patient with increasing hypoxia, connect this framework to tests that can be ordered for a hypoxic patient, and then analyze the advantages and disadvantages of these tests in an acutely hypoxic patient. And so the session that I designed was a series of interactive cases for hypoxic patients. All these cases were based off of patients that I saw, and it went through 5 cases. So the first case was the case of a spontaneous pneumothorax that occurred on the floor in the setting of somebody with cirrhosis. Second was a pulmonary embolism in the setting of COVID-19. Another was a flash or hyperacute pulmonary edema in the setting of somebody with multivessel coronary artery disease who was awaiting a CABG and became hypertensive. The fourth case was a patient with acute mitral valve regurg in the setting of being admitted for an NSTEMI 3 days ago who developed a flail mitral valve. And then the fifth case was kind of a bonus case, and it was somebody who was pretty comfortable appearing, but their SpO, their pulse ox was showing an oxygenation in the high 90s, and it turns out that oxygen tubing had just been rolled over by one of their wheels, so they weren't effectively getting the oxygen that everybody thought they were. And so each case followed a similar pattern where there would be a page from a nurse that basically just said there was a patient who was hypoxic, appearing uncomfortable, and then they proceeded to like kind of the choose your own adventure part of the case where there was a handoff option, history from a nurse, history from a patient, or physical exam. You could click each of these boxes and it would take them to the relevant section. So if they click the physical exam, it'll give you the vitals and also just a general physical exam or the relevant physical exam for the patient. They click labs, it would take them to a secondary menu of labs, and the organization for this is the tests that come back first, like the point of care blood glucose comes back pretty immediately, and ABG, VBG, lactic all come back relatively quickly. And then it takes a little bit longer to get a troponin and a CBC and a BNP. So that's the organization of the labs. And then for the imaging, I pretty much let them order whatever they wanted to, including EKG, point of care ultrasound, and then a chest x-ray. And so for this case, this is the case of the spontaneous pneumothorax. If they were to go into the point of care ultrasound section, they'd have the option of doing a lung ultrasound, and this lung ultrasound is a YouTube, just a basic 10-second YouTube video that I found online that showed absence of lung sliding. And so I could point it out to them, and then if they, in this case, if they order a chest x-ray, what you'd see is on this right side here, there's absence of interstitial markings, diagnostic of a pneumothorax. And so the diagnosis of this case is pneumothorax, and we just discussed briefly about the management of the patient. The next section was, well, in between the cases, I used a hypoxia framework to structure my didactic portion. The framework that I used was basically, is the hypoxia from the lungs or is it from the heart? And then from the lungs, I broke into 5 subsections: the airways, alveoli, interstitium, vessels, and pleura. And then the heart, I also broke up into 5 subsections: the valves, the vessels, the myocardium, the pericardium, and the electrical system. There were 2 other categories that I wanted the patient or the students to think about, but of course the emphasis is on the heart and the lungs. That is the chest wall if somebody has like obesity, hypoventilation system, and also if none of those 3 categories explain what's happening to the patient, they should also consider like neuromuscular problems like myasthenia, Guillain-Barré, or opioids leading to decreased respiratory drive. And then I connected this framework to possible workup that can be done on the patient. For example, if they were to get an ABG or a VBG, PCO2 is very helpful in determining if the problem is in the airways. Usually these patients will have an increased PCO2, or a problem in the chest wall will also lead to an increased PCO2 because they're having difficulty clearing out carbon dioxide. But relatively normal PCO, if the PCO2 is normal, that means they don't have a problem clearing PCO2, so the problem lies somewhere else in the alveoli, interstitium, etc. And then I also then would talked about the difference between an ABG and a VBG, and why, you know, ABG is more accurate, VBG, if they have a peripheral IV, is easier to draw. So that was the kind of like a example of a compare and contrast of, or advantages of disadvantages analysis of some tests that can be drawn. Overall, this simulation session was, or this case series was evaluated by a pre and post test. The first couple of questions were asking the students to rate their confidence in addressing both the diagnosis of hypoxia and the management of, or the diagnosis of the cause of hypoxia and the management of hypoxia. And as you can see, there was increase in the patient's confidence both after taking the course. There was a more drastic increase in the increase in their confidence of managing hypoxia. It specifically went up on average 1.33 points. And then there was also a knowledge-based assessment where that was given both pre and post the course. As you can see, the first and second questions did show some improvement. The second question showed drastic improvement. The third and fourth question didn't show any improvement. And actually, so the third question was addressing management of flash pulmonary edema, specifically starting a IV nitroglycerin drip to offload the heart. Unfortunately, when I gave the presentation, I actually never got to this case. I informed the students that they could use the PowerPoint to go through the case if they wanted to, but I think that's one reason that this answer did not show any improvement. And then the fourth question was a diagnostic step in somebody with a suspected PE, so order a CT A of the chest with a PE protocol. I think part of the reason that this didn't show any improvement, I mean, 5 students got it right before even taking the course. And so that would be one reason it didn't go up. And then in conclusion, I'd say overall taking this course, of which my workshop was this part of it, students' confidence in their ability to diagnose and manage an acutely hypoxic patient increased. Although according to the statistical analysis I did with the Mann-Whitley-U analysis, there was not a statistically significant increase. The p-value for the diagnosis was 0.17, and the management of hypoxia was 0.12. I think this had something to do with the small number of, or the low number of students that were taking the course, making it difficult to establish statistical significance. And they also, I'd say, generally, in the comparison of ABG versus VBG, and a significant increase in the patient when the students understanding that they shouldn't make decisions purely based off of a pulse ox reading, but no more of a clinical assessment of the patient. Those two things significantly increased in response to taking this course. Next steps. It was hard for me to know how long this would take because it's so interactive, and I didn't know how long each case would take. Having done it once, I feel like there's enough material where I could easily do it over a 2-hour workshop. So if that is a possibility, I think I'd like to have a 2-hour session to go through all this information. And then also, as I was presenting the case, there's a huge difference between going to a rapid where you are the person who has to do the exam and then use the ultrasound, as opposed to being in a lecture where you can kind of just shout out the physical exam and ultrasound. So I was thinking about it, and I'd like to redo the physical exam portion where I'd have, like, in the ultrasound portion, so I'd like to have an ultrasound in the room and have students demonstrate, like actually demonstrate on a mannequin or something, what physical exam maneuvers and how they would get the ultrasound images, instead of them just asking for like an ultrasound of the heart. And then I'd also like to simplify the hypoxia framework that I use. I think focusing in on the airway, alveoli, interstitium, and vessels in particular, and then within the alveoli, breaking it into like cardiogenic and non-cardiogenic components to get the heart. I think it'd be much simpler. As it stands right now, there's a lot of information in the hypoxia framework and a lot of busyness there, and I think that could be simplified further. And then the ultimate next step would be to expand this format to other chief complaints like altered mental status. Anyway, sorry that I won't be able to be there in person. I appreciate you listening to this video. If you have any questions, feel free to email me and reach out. I appreciate you taking the time.